All right, well, welcome everyone to our Hot Topics in Research Ethics webinar series. I'm going to hand over to my colleague, I'm Gur-Arie with the Berman Institute of Bioethics, but I'm going to hand over to my colleague, Julia Patrick Engesan, to give us a bit of an introduction for today's webinar. So Julia, over to you.
All right, okay, thank you, Joe. So good morning, good afternoon, good evening to all the audience, right? And I am Julia Patrick Engesan. I am from Faculty of Medicine, Universiti Malaya, Kuala Lumpur, Malaysia. Welcome to the session on the Hot Topics in Research Ethics. This is the webinar series sponsored by Masters of Research Ethics Studies, and this is a collaboration between Universiti Malaya and the Johns Hopkins Berman Institute of Bioethics, and our project is funded by NIH. And we have been, this is the second cycle of our Hot Topic Research Ethics, and in the previous, these are the list of the previous speakers, right? You can see there they come from both the US side as well as the Asian side, and we always have 4 speakers for one cycle. So now we're on our 3rd speaker for the 2nd cycle. Right, next slide, Joe. And I would also like to take this opportunity to introduce you to the project that is supported by the NIH grant between the 2 institutes. This is the Master of Health Research Ethics, or we call it MORE. MORE is a Research Ethics Master Program, as you can see, and it is a 1-year full-time program. Application deadline is usually by May, and our intake used to be September, but because of COVID, we are starting now in October. So MORE aims to produce graduates equipped with the knowledge and skill necessary to engage in the field of health research ethics. And right, as I previously said, this is a program developed in collaboration between Faculty of Medicine, Universiti Malaya, and Berman Institute, Johns Hopkins University. And we also, this program also offer 10 scholarships for applicants from low and middle income Southeast Asian countries. And we are now in our 3rd cohort, and is planning to start our 4th cohort this October. Right, so with regards to this webinar, so please type your question in the Q&A or chat box, and me or Joe, we try to address them during the discussion. And this session will be recorded and will be made available afterwards in the MORE and Berman Institute website. Over to you, Joe.
Thank you very much, Julia. So I have the pleasure of introducing our speaker for today's webinar. And I'm pleased to say that it's not only a dear colleague of mine, but a postdoc fellow that we have at the Johns Hopkins Berman Institute of Bioethics with us. And Rachel Gur-Arie is one of our fabulous fellows in global infectious disease ethics with the Berman Institute, which is a jointly appointed position with the University of Oxford Ethics Center. Pleased to share this presentation today on behalf of our program, and which builds significantly on Rachel's work previously as a PhD doctoral student, as well as her research that she's been conducting over the last several years on issues involving vaccine hesitancy amongst healthcare professionals and workers. So today, Rachel will be speaking on some of the ethical dimensions of that kind of research, of vaccine hesitancy research. So I think without further ado, we'll hand over to Rachel, who'll be presenting for about 30, 45 minutes. And as Julia mentioned, we'll have an opportunity for some discussion afterwards. So please do post any questions in the chat. So Rachel, over to you.
Thank you. Thank you, Joe and Julia. I'll begin. So as Joe mentioned, my name is Rachel Gur-Arie, and I am a postdoc at the Berman Institute of Bioethics, supported by GLIDE, the Global Infectious Disease Ethics Collaborative, between the Wellcome Center for Ethics and Humanities at the University of Oxford and the Berman Institute of Bioethics at Hopkins, supported by the Wellcome Trust. Today, I'll be speaking about navigating the ethical dimensions of vaccine hesitancy research. Vaccine hesitancy is a topic that obviously has received heightened interest and investment and resources, and rightfully so, due to the COVID-19 pandemic. But it's also important to know that vaccine hesitancy research has decades of sort of history leading up to this moment. And so it's important to take that history and that work into consideration when not only we conduct vaccine hesitancy work today in the context of COVID and the context of other diseases in the COVID-19 pandemic, but also when we're building our study or such studies and when we're thinking about the ethical dimensions of this work. So today I won't be talking about, or the focus of the topic won't be on sort of what vaccine hesitancy is and why it's important, though I will briefly introduce that, and sort of what results of vaccine hesitancy studies look like, though I will briefly touch on that just for the purpose of sort of rounding out the presentation. But today I'll focus on really the ethical questions and dimensions that arise from vaccine hesitancy work and research that I think is really an emerging field of at least conceptual thought, as well as empirical research in the space of vaccine hesitancy. Sorry, my slides are skipping. So as I mentioned before, I will briefly introduce what vaccine hesitancy is and what vaccine hesitancy among healthcare workers is, at least how I define it. And I'll sort of try and justify for you all why it's important, and why specifically vaccine hesitancy among healthcare workers and researching it is unique in compared to researching it among other populations or among the general population at large. Then I'll dive into exploring the ethical dimensions of vaccine hesitancy research by focusing in on 3 specific ethical dimensions. Of course, there are many more, but for the purposes of this conversation and discussion, I'm going to focus in on 3. Recruitment considerations, minimizing risk and stigma, as well as respectful data collection. And then I'll give 2 examples of research studies that I've individually, personally been involved in, either by leading or being a team member or both. One is my doctoral research that I conducted in Israel just prior to the COVID-19 pandemic. So as I mentioned before, it's important to sort of think about the ethics of vaccine hesitancy, not only in the context of COVID, but also before and sort of after. And so the Israeli study is an example of a study that happened pre-COVID, just before COVID. As you can see, it finished in 2021. And then secondly, I'll introduce a study titled The Ethics of COVID-19 Vaccine Hesitancy Among Healthcare Workers in Ethiopia, which together with Joe, we're working with colleagues in Ethiopia to think about vaccine hesitancy and research vaccine hesitancy among healthcare workers among Ethiopia. And that's specifically focused on COVID. And then finally, I'll end with some takeaway messages. Before I proceed, I do want to acknowledge Gur-Arie for his guidance and sort of help in building this, this presentation. It's a topic that we've been thinking a lot about together. And so what I'm presenting today is not my own. It's a product of teamwork with Joe and other colleagues across multiple studies. And so let's dive into how I personally define vaccine hesitancy. I take the definition from the SAGE Working Group on Vaccine Hesitancy in 2015 published this definition: to delay in acceptance or refusal of vaccination despite availability of vaccination services. So vaccine hesitancy is context time and place specific. Vaccine hesitancy can look very, very different depending on where you are, who you are, what the vaccine is, what the disease is, what access looks like, etc. And as you can tell by the definition here, it's not just the refusal of vaccination. So I think in the context of COVID-19, vaccine hesitancy, at least in the popular media, has sort of evolved into being a synonym for vaccine refusal. So if someone is vaccine hesitant, perhaps we automatically assume that they're not going to get vaccinated, or they're not interested, or they're refusing vaccination. But as you can tell by this definition, vaccine hesitancy is much broader than that. It includes vaccine refusal, but it also includes a lot of other behaviors that perhaps include delaying vaccination, or being weary of vaccination, or even having a question about vaccination, even if someone plans on getting vaccinated or is sympathetic toward vaccination in the first place. The fact that someone could have a question or a concern about a vaccine could also mean that they're vaccine hesitant. But just because someone is vaccine hesitant doesn't mean that they're not ultimately going to get vaccinated. On the other hand, just because someone is vaccine hesitant doesn't mean there is a guarantee that they are going to get vaccinated. So it's really this sort of behavioral phenomenon where there's a lot of gray, and there's a lot of room also for public health and to step in, or medicine, or whoever someone is interacting with, to step in and hopefully address an individual's concerns toward vaccination, with the ultimate goal of them getting vaccinated. But I'll talk about that goal later, because that is an ethical statement in and of itself. So vaccine hesitancy is influenced by complacency, so not trusting a vaccine or a provider, for example. Convenience, so how convenient it is to get a vaccine, whether or not you have to take 5 buses and walk 20 miles to get a vaccine, or whether or not the vaccine is underneath your place of living and takes you 5 minutes to get to. And vaccine hesitancy is influenced by competence. So how much someone perceives or does not perceive a need or a value of vaccination. So how important is vaccination to a given individual or a given community? I think a better way to sort of conceptualize vaccine hesitancy is on a continuum here. I think this visual does it beautifully. So as you can see, according to this visual spectrum, which is also in the shape of a vaccine, conveniently, vaccine hesitancy ranges from ultimate refusers to ultimate acceptors. However, you can see on the spectrum of vaccine hesitancy that most individuals, most people in the general population, in any subpopulation really, are vaccine hesitant. And that's okay, right? We actually wouldn't, in my opinion, want folks to be ultimate acceptors of all vaccines all the time, because that would mean that they're not engaging and not asking questions about public health and public health advancements. And that engagement is really important, in my opinion, in order to maintain trust in public health as sort of a field, as an authority in general. So it's totally fine and okay and expected that people are vaccine hesitant. As I mentioned earlier, in the context of COVID-19, the topic has really become stigmatized. And now to call someone vaccine hesitant is really to stigmatize them in many communities and many places across the world. With that in mind, anti-vaxxers or people who refuse vaccines may not identify themselves as anti-vaxxers, but the common term known as anti-vaxxers are included on the spectrum of those vaccine hesitant. But as you can tell, they are on one very extreme side of the spectrum, and they account for a very, very small percentage of those vaccine hesitant or of the general population. They usually account for less than 5% of populations in general. So what that means is that a very, very small population and group has a very, very loud voice oftentimes in voicing concern and anti-vaccine sentiments in the broader conversation surrounding vaccination and vaccine hesitancy. And so oftentimes it's actually really confusing to understand what exactly the state of the ground is for a population regarding vaccine hesitancy, because you hear really, really loud voices, but they're ultimately coming from a minority. So the voices of the anti-vaxxers are not representative of necessarily representative of the concerns of the wider population. So that's how I addressed vaccine hesitancy in my work. And I personally investigate vaccine hesitancy in the context of healthcare workers as a population. Researching vaccine hesitancy among healthcare workers is interesting for a variety of reasons. And actually, a lot of the motivation for me investigating vaccine hesitancy specifically among healthcare workers is because of the ethical dimensions that arise when we investigate vaccine hesitancy among healthcare workers. Why? We expect a lot as a society from our healthcare workers. We expect them to be professional, competent. We expect them to be honest, altruistic, always provide us with the highest level of care, maintain appropriate relationships. Healthcare workers are a type of population that you expect when you receive care from them, no matter where you are in the world. So whether or not you're in your hometown or you're very, very far away, you expect that when you interact with a healthcare worker, you are receiving a high level of care, the highest level of care possible, and that you're receiving honest care so in the sense of you expect the healthcare workers to have your best interests in heart, in mind, when they're treating you as a patient. And that's really interesting when we think about those responsibilities and expectations in the context of vaccination, but I'll get there. Another important point, which is relevant when thinking about vaccination, is the populations that healthcare workers interact with and care for at a disproportionate level compared to other groups or populations. So healthcare workers disproportionately care for immunocompromised patients. They are disproportionately caring for the elderly and for children. And what we also know about, or at least what research has suggested regarding these three groups of populations, is that immunocompromised patients, the elderly and children, benefit the most from mass vaccination because they are at highest risk on average from population level diseases. And so there's even a higher interesting or a more interesting ethical question regarding the vaccination behaviors of healthcare workers because of their interactions with these particularly vulnerable populations, in addition to the general public and other patients that they're interacting with on a daily basis. So why focus on that? Why focus on researching vaccine hesitancy among healthcare workers? So healthcare workers, in addition to all the points I mentioned before, are also key connectors of vaccine hesitancy and confidence in a population. So what healthcare workers think about vaccines and how they prescribe vaccination really matters. They have a unique societal position toward both their patients and the public. Healthcare workers are not only healthcare workers in their white coats or professional garb or whatever, they're also members of the public. So they finish their shift and then they go stand behind you in the grocery store or go work out next to you in the gym, et cetera. So it's not like they're separated from the public. They're obviously an authority figure on health and communities, but also a part of the community at the same time. And yet healthcare workers have been treated differently population-wise as a group when it comes to vaccine policy. So generally speaking, vaccine policy for healthcare workers is different on average than vaccine policy for other adult populations, even other adult occupational groups. But why? I think that, there's been a lot of work on this subject in both a pre-pandemic and COVID-19 context. But I think that a lot of the work that's been done has relied on a lot of assumptions. And at least the ethics of this question hasn't been developed in the literature very well, at least now. And I do think that that's changing. And I do think that we're seeing different pieces coming out that are really diving into, from an ethical perspective, why healthcare workers are treated differently. I think we all might have a hunch, like we all at face value when asked, should healthcare workers be treated differently when it comes to how vaccines are regulated? We all, or most people, I think in my experience, generally say, well, of course healthcare workers should be treated differently. Of course we should mandate vaccines for them or have a different policy in place for them, et cetera. But why? Why? Justify it. Root it in sort of ethical principles and in best available data. And then that's the hard part, right? And so that's, I think, what this work is trying to do and what this presentation is trying to tease out in some sense as well. So obviously healthcare workers' occupational burden has been peaked during the COVID-19 pandemic specifically, although healthcare workers, had an extraordinary occupational burden and load pre-COVID-19 as well. And so with this in mind, healthcare workers have a multiple professional and personal commitments. They have a lot on their plate at work, and they're also individuals balancing a lot of personal commitments. So where is the place of public health? Where is the place of vaccine policy? How do we integrate ethically our work on vaccine hesitancy in addressing vaccine hesitancy among healthcare workers? Emphasis on ethically, right? That's what we're going to talk about today. And I believe that policy implementation requires striking an appropriate balance between, yes, healthcare workers' occupational responsibilities and duties, but also their attitudes toward the vaccine and the socio-political context at hand. So whether or not we have enough vaccines, whether or not we're in a pandemic, et cetera. So this sort of challenge mess of a slide, all these complicated factors that I introduced to you, in my opinion, requires careful ethical analysis and empirical data collection when thinking about researching vaccine hesitancy among healthcare workers. Okay, so as I said, I was going to briefly introduce that just so we're all on the same page and so you can understand how I approach researching vaccine hesitancy among healthcare workers. But now let's dive into specifically the ethical dimensions of vaccine hesitancy work, which is something that, as I mentioned earlier, Joe and I and other colleagues have been developing specifically over the last year and a half or so. Beginning with recruitment considerations. And so when we're interested in investigating vaccine hesitancy among healthcare workers, but when we're particularly interested in the ethical dimensions of it all, both from sort of a content perspective and as well as implementing sort of ethics into how we build the study and really being sensitive to that, we want to focus on a multiple recruitment considerations. So we want to recruit both the vaccinated and the unvaccinated. Why? Because in my opinion, from just like a research perspective, when you conduct vaccine hesitancy research, it's really important to sample people from across the spectrum of vaccine hesitant views or not. So if you're researching vaccine hesitancy and you're only speaking to people who are ardent vaccine believers or are ardent anti-vaccine, have anti-vaccine sentiments, then your data is going to be flawed. And so with this in mind, I think a way of addressing this is recruiting both. So avoiding oversampling of one group, so avoiding only talking to doctors who are pro-vaccine, or avoiding only talking to nurses who are hesitant toward vaccine, and instead, in the context of healthcare workers, sampling a variety of people with vaccine hesitancy views, different vaccine hesitancy views, as well as a variety of occupational groups. So sampling across the hierarchy of healthcare workers. And in my opinion, that should also include non-clinical essential workers. So people who work as food staff, people who work as cleaning staff, they are also part of the healthcare setting, and therefore I believe that we should hear their voices. A lot of the times in the past, a lot of work on vaccine hesitancy among healthcare workers has focused only on physicians and on nurses. And in my opinion, this is a place where we can improve ethically and sample a wide variety of occupational positions. So another way to address recruitment is to sample populations that are also stakeholders. So sampling people who can benefit from the research outputs. So for example, if we're investigating vaccine hesitancy among healthcare workers in a given healthcare setting, then we don't necessarily want to focus our recruitment on healthcare workers outside of the healthcare setting that we're focused on building policy for. We want to sample people who are going to benefit from the findings, right? So if we find that there's a lot of vaccine hesitancy in a given institution and we build a policy to hopefully address that ethically, then we want to make sure that the people we talk to who informed our research are also benefiting from it. Another way of interpreting this sentence is to broaden sort of the sampling of a given population that you're interacting with beyond healthcare workers in order to get sort of a broader understanding of vaccine hesitancy policy and how that impacts healthcare workers. So you can sample healthcare workers, and you can also sample, in my studies, what we've tended to do is sample both healthcare workers as well as decision makers, like in the Ministry of Health or at the administrative level of the hospital, for example, that's making decisions, because that way you can talk to both people on the ground who are being affected by the policy, for example, so the healthcare workers themselves, as well as the people who are building that policy. And that way you get like a broader picture of how decisions regarding vaccination among healthcare workers are built. Finally, it's really important to sample through trusted institutions and individuals. And so oftentimes in my personal experience, I've run into a lot of questions, disproportionately a lot of questions comparatively to other work from study subjects. So for example, healthcare workers asking me how my study is built and how I found them, and why I'm speaking to them specifically and how I got their contact information. And we'll talk about this later. And I think that this is because vaccine hesitancy is a particularly sensitive topic and oftentimes stigmatized topic in many communities. So people are disproportionately often interested in figuring out how you found them. And so for this reason, it's really important to sample through trusted institutions and individuals. For example, sampling through their boss, or through their department head. So if a physician is working in a given department, they trust their department head is their boss at the same time, and that raises a lot of questions, but you got to them through someone that they know, and that's really important, versus you found their name on a list from the administration who perhaps they don't trust, perhaps they're concerned about, etc. And so it's important to sample through trusted individuals, institutions, etc. Secondly, a really huge, one of the major recruitment considerations is ethically determining one's vaccination status. So in my opinion, you don't start in the context of qualitative research, you don't start the interview with, did you get vaccinated or not? No, that's like a surefire way to lose trust, to have the interviewee be weary of you and to feel stigmatized by you as the interviewer, right? In my opinion, you want to build up to the question. You want to establish rapport instead of leading with it. So I'm not sure if I mentioned this before. I think I forgot, but I'll mention it now, that I am talking about these considerations in the context of qualitative research. So I'm a qualitative researcher, and that generally uses primarily interview methods. So when I talk about literally talking to people about their vaccination status, is because usually I'm literally interviewing them to learn more about, okay? So you can ask that vaccination question up front or later in the middle. In my experience, you don't want to ask it up front. You want to begin your interview with, how are you? Who are you? Where are you from? What do you do? Tell me about yourself. Tell me why you're interested in this research. Tell me why you decided to become a healthcare worker, et cetera. Build trust with them. And then later on, perhaps ask them about their vaccination status in an appropriate and respectable way. And finally, this ties into the importance of minimizing the potential for bias. So as I mentioned, you want to establish trust with your interviewee and also with sort of the institutions you're working within. You want to disclose personal biases if relevant. So depending on who you are as a qualitative researcher, you might find that you are disproportionately have, a tendency to talk with a tone of being very, very pro-vaccine. And you might want to disclose to the participant you're working with saying, I know that my tone, my questions may seem like they are leading, or I may phrase them in a way that makes you feel like you have to answer a certain way, but this is not true. This is a personal bias of mine, etc. That might be a little even too far to disclose up front, but there are ways to disclose your personal biases depending on who you're talking to and where you're working, that allow you to establish trust better with the interviewee and make them feel more comfortable. And finally, you want to admit you're wrong when you're wrong. Okay. You want to, we're all human. We make mistakes. This is a really complicated topic to be conducting research on, especially when you're investigating the ethics of vaccine hesitancy specifically. So there's the ethical dimensions of vaccine hesitancy. And then there's the goal of learning more about the ethics of vaccine hesitancy, which is sort of something that we can talk about in the Q&A if relevant, because today we're talking about the ethical dimensions of vaccine hesitancy work. But because it's such a complicated, messy topic, oftentimes, if you make a mistake, you just want to admit you're wrong, and people appreciate that and then move on, but not try and cover up your mistakes or pretend like you're right. That's a surefire way of sort of losing trust and rapport with people you're trying to speak with about a very sensitive topic. Secondly, minimizing risk and stigma in vaccine hesitancy work. There are many consent-related challenges. So when we want to speak to healthcare workers about their vaccination status, it's not like healthcare workers start lining up, right? I mean, you might get lucky and you might have healthcare workers that are disproportionately interested in talking to you at a given healthcare institution. But most of the time, that's not the case. Most of the time, healthcare workers are very weary about sharing their views on the topic because they don't want to put themselves at risk or in trouble with their boss, right? So as I mentioned before, healthcare workers are people too. And yet there's this societal expectation that all healthcare workers perhaps be disproportionately more pro-vaccine or disproportionately more trusting of vaccines. Research, even leading up to COVID-19, and certainly during COVID-19, has shown this not to be true. Healthcare workers are actually disproportionately hesitant toward vaccines. And so with that in mind, they're not going to be rushing to talk to you, a researcher, about how they're so hesitant and concerned about a vaccine, because that makes them look bad oftentimes and maybe puts them at a risk of losing their job if they're viewed one way or another. And so you want to make sure that the consent process really has the healthcare worker understand that their privacy is protected, which we'll talk about later, and that this interview and research doesn't impact their employment status, etc. There's also a really important point and challenge, I think, as the researcher, of whether or not you're going to address misconceptions or misinformation during sort of the research process. So a lot of the times when healthcare workers or people come to talk to you as the researcher, as someone from a university or as someone who is the sort of authority figure on vaccines, they come less to share their views with you and more to ask you questions, sort of like in a clinical interaction, like they're coming to talk to a doctor and ask questions about the vaccine and whether or not it's safe for them to take, et cetera. And so this is a really tricky area because you need to decide, are you going to address them? Are you going to answer their questions? Are you going to then add bias into the interview by sharing with them what you think about a vaccine, when you're not interested in learning about what you think in the research? You're interested in learning about what they think, and you don't want your thoughts to impact their answer, right? But then, there's a trade-off by answering or addressing a misconception they have. Maybe that would, clarify something for them, and they would share their thoughts with you that they otherwise wouldn't share. So if, when, and how are you going to address these misconceptions? I tend to err on the side of not addressing misconceptions or avoiding having to address them, but I can talk about that later as I give some examples. And finally, it's super important to protect the data confidentiality, de-identify all data, delete data appropriately when you're finished using it, to make sure that the data that you collect is completely de-identifiable. Should it get in the hands of someone else, no one would be able to trace that quote back to the interviewee, for example. And B, destroy it when you're not using it. So once you conducted your analysis and you're finished, you're done with it. So it's not hanging out somewhere just waiting to fall into the hands of someone else who doesn't need to see it. Secondly, a huge bucket in this minimizing risk and stigma category is really avoiding stigmatization. As I mentioned earlier, it's a super sensitive topic, generally across the world, obviously depending on where you live and where you're conducting the work, more or less. But with this in mind, I think I've addressed this sort of already, but I want to reiterate, it's really important to promote the individual's privacy who is participating in the research. And, when you're perhaps sharing findings with the institution, for example, it's important to also obscure certain aspects of the study population in groups. So if you disproportionately sampled people, for example, from one department in a healthcare setting, you want to make sure that maybe you don't share that information with administrators, right? Because then maybe administrators at the institution would see, oh, this department has concerning views regarding vaccination. We should maybe intervene more there in comparison to another department. And I don't think that that is necessarily always appropriate. That could be appropriate. For example, I'll share later an example of where that was appropriate in my experience, but you can't make that assumption. You also just generally, when sharing the findings of this research or when proposing the research, you might want to obscure aspects of the study population from the point of view of, okay, I'm not going to tell exactly the hospital that I'm conducting the research in to stakeholders, for example, that I'm talking to, the decision makers that I'm talking to. I'll say a hospital within 20 miles of the capital city, instead of saying the name of the hospital where I conducted the research, et cetera. There's many different ways to get at this, and we can talk about this more very soon. I actually want to maybe finish on this slide with maybe brief examples and then jump into discussion. So finally, we have respectful data collection as a pillar. And there's a lot of challenges that come with this one. You can come across as judgmental during qualitative interviews towards unvaccinated people, or you can be seen, or both, be seen as promoting vaccination through your conducting of the interview. So you definitely don't want to come off as judgmental or therefore stigmatize people in an interview. That is definitely a basic of qualitative research. You want to be as objective as possible in the context of a conversation between two people or in a focus group, et cetera. And you don't want to go into the interview or the research seen as being promoting vaccination, because then you're going to disproportionately sort of push certain people away and invite certain people in, and that's a huge bias in the work. And so it's really a huge dance in this kind of work. Being able to research and understand vaccine hesitancy among healthcare workers without being seen as being on one side too much. And this also ties into that point of how much you address misconceptions or misinformation towards vaccines during the interviews. That ties in here as well. Strategies to sort of combat these challenges is to, as a researcher, really do your homework and understand the distinctions between vaccine hesitancy as a phenomenon, as well as, structural barriers to vaccine access. So a lot of the times, someone isn't necessarily holding personal beliefs that are skeptical of vaccines. They've just never had the opportunity to get vaccinated themselves because of a structural barrier. Okay. So a lot of the time when you have a personal experience with something, it's a lot less scary or a lot more scary. But what's the most scary is the unknown, right? When you don't know something or someone, when you've never met something or someone, it's the ultimate fright, right? And so it's important to be able to delineate as a researcher when someone is expressing true vaccine hesitancy from a personal point of view and vaccine hesitancy that's deriving from, systematic structural barriers. It's also very important on this homework theme, doing your homework theme, to recognize variation in perceived sensitivity to vaccines and vaccine hesitancy globally. So there are communities and countries across the world that are disproportionately more or less vaccine hesitant, disproportionately more or less religious. Oftentimes religion is a huge contributor to vaccine hesitancy. recently, in the wake of COVID-19, disproportionately more or less affiliated with one political party. I would say that that's the #1 contributor in the United States right now for vaccine hesitancy, not necessarily religion, but political affiliation. And so it's super important, once again, as a researcher, to really, really know your stuff, know the context that you're researching within, who you're talking to, and what might be concerns or influences upon their views toward vaccines, and not sort of have those be confounders in your interviews. And then finally, just as it's important to respectfully collect data, it's super important to respectfully save it, share it only within the approved study team, and destroy it when you're finished. So I'm running out of time, but I do want to give examples of, just maybe I'll touch on one. I'll touch on our study that we're currently conducting in Ethiopia, together with colleagues in Addis Ababa, the hospital, Tikrit hospital there. We have not conducted the study yet. We're almost ready to begin data collection. But the whole process of designing the study, which first of all, its research aim is to develop a contextualized understanding of factors contributing to vaccine hesitancy among healthcare workers in Ethiopia during the COVID-19 pandemic, with an emphasis on normative influences and understanding how healthcare workers there sort of conceptualize their local healthcare system and operationalize their vaccine-related ethical obligations. So this vaccine hesitancy study is really, really explicit in being interested in not only investigating vaccine hesitancy among healthcare workers, but also the ethical dimensions of vaccine hesitancy among healthcare workers, which I think is new. I think a lot of studies are being conducted now on vaccine hesitancy among healthcare workers regarding the COVID-19 vaccine, but not many studies are explicitly interested in their vaccine-related ethical obligations. And so it was really interesting for me going through the process of designing this study, because of the explicit emphasis on the ethical components of vaccine hesitancy that we're interested in investigating. We really thought about exactly who we are going to talk to and what we are going to talk to them about. And so the study design actually looks a lot like other vaccine hesitancy study designs that are qualitative that I've been a part of. So generally, recruitment is happening both among healthcare workers and policy and practice leaders. And interviews are being conducted one-on-one in a private location, and we're coding using qualitative software, et cetera. However, designing the recruitment process was really unique. So we had to think about how we're going to recruit both unvaccinated and vaccinated healthcare workers with getting representation from multiple occupational groups. This is really tricky because you can't really control who's going to be interested in your research study. You sort of just put it out there and hope for the best at the end of the day. But you can design it in a way that you think will best attract a diverse sort of pool of those interested. And so we'll see how successful our methods were really soon, but we are confident in them. On the policy and practice leader side, or the stakeholder policymaker side, we're interested in people who are involved in both establishing and or implementing guidelines, both within the specific hospital and also across Ethiopia, as well as regional and national health authorities. So oftentimes you have to expand or limit your recruitment pool depending on how many people you think will be willing to talk to you. And so oftentimes it's not enough just to target administrative leads. You have to also target higher ups in the Ministry of Health, et cetera, in order to, at a regional and a national level, often to get a more sort of full picture of the situation regarding vaccine hesitancy among healthcare workers. So here is actually the slide I want to flash before we dive into Q&A. And you can see how we structured sort of the themes of each of the interview guides for both healthcare workers and policy and practice leaders. You can see it's not the same interview guide, copy and pasted for both. And I think that's really important. And I think that's what delineates like good vaccine hesitancy work to great in my opinion, I mean, not that I don't want to toot our own horn and say that our work is so great, but I think that when you when you personalize the interview guides for your target population and not just use sort of the basic template on vaccine hesitancy, you really speak to the expertise that both populations can give you. So on healthcare workers, we're really interested in learning what exactly they have to say. We want to hear about their personal and professional conflicts. We want to hear about what they think about vaccines. We want to hear about their experience during the pandemic because that potentially influences their vaccination behavior. But on the policy and practice side, we're less interested in asking the leaders themselves, are you getting vaccinated or not? We're more interested in asking them what their impressions of healthcare workers are, how that impacts how they build policy, how they implement evidence into their policy making, et cetera. And these are questions that healthcare workers, for example, wouldn't be able to answer. So that might seem like a given, but actually it's really not when conducting sort of qualitative vaccine hesitancy oriented research. So I think I'm going to stop there. Thank you so much for listening, and let's jump into Q&A.
Wonderful. Thanks so much, Rachel, for sharing that. It's really interesting, especially to hear your thoughts on some of the connections between methodological decisions and sort of ethics in qualitative research in this context. So thank you. So as others are writing questions in the chat, in the Q&A.
Yep.
So Julie, did you want to raise one? Yeah, go ahead.
Right. So there is a question from Deroda, and it's about, I just read out the question, yeah. It would be great to hear some citation for the interesting statement that even pre-COVID, it was established that healthcare workers are disproportionately vaccine hesitant with respect to the general population. Could you please point us to that research?
Yeah.
Yes.
Thank you. Because I've been thinking about this for so long, I actually can tell you exactly researchers who are working on this. So I would point you to Heidi Larson's work out of London. She runs the Vaccine Confidence Project, and her team were actually some of the leading researchers, at least in a European context, showing how healthcare workers, first of all, they researched the state of vaccine confidence sort of globally and across multiple populations. And they've been showing for the last really 10 years how the state of confidence in vaccines globally is decreasing. But specifically within the context of healthcare workers, Amelia Karafalakis is a researcher in her group. And she's been writing a lot pre-COVID on how hesitant healthcare workers are, specifically within the European context, toward vaccines, specifically regarding the influenza vaccine. And so sort of they've really led the charge for other researchers across the world to do similar studies. And I know from my personal experience, similar findings have been found in the United States, as well as in Israel, where I conducted my doctoral work. And so my familiarity with that space is really within high-income countries. But I think specifically in the context of COVID-19, there's been an interest to research this hesitancy even more in low-income countries, low and middle-income countries as well. And so now it's certainly established as a global phenomenon. And I'd welcome you to email me. I can send you more citations as well. Thank you.
All right, thanks, Rachel. And right, I'm not sure there's a question from Amir, but I'm not sure whether it's a general or can you have a look at it, Rachel? It's about researcher, taking his name. I'm not sure whether it's related to vaccine study or not.
Yeah, and I'm not sure. So it says the researcher they participated in the study. A researcher took their name and continued with questions. Is taking my name appropriate? So I think it's a complicated question because I don't know what the researcher is doing with the name. I would assume that the researcher took your name to sort of just know your name and be able to establish more of a friendly conversation, because it's good to know people's names in order to address them by name and sort of be more respectful. But I'm not sure what they did with your name afterwards. I would hope that they didn't attach your name to your data when they're and analyzing the data. But I think that's something that you can definitely ask them about, follow up with them.
So the next question is, it's related to your topic just now. So along with marginalized group, why is it important to interview stakeholders in terms of vaccine hesitancy?
Yeah, thank you for that question. I think perhaps this is my personal bias because I'm particularly interested in policy making, like using this research to inform policy. And so I'm always interested in learning about, at the same time that I'm speaking to marginalized groups or groups that are particularly perhaps stigmatized on the issue, like healthcare workers, interested in learning what goes on behind the scenes in order to better inform why the healthcare workers are speaking that way, why they have those opinions toward policies, and vice versa. And so for me, talking to policymakers really just provides more of a holistic understanding of sort of the situation at hand from a policymaking perspective. But if you were only interested in learning about collecting empirical data on vaccine hesitancy among healthcare workers, then perhaps you wouldn't need to speak to policymakers. But in my work, I'm interested in doing both.
All right, so thanks, Rachel. There's no more question, but I do have one question to ask you, right, with regards to disclosing your personal bias, right? So I'm just wondering, sometimes when you do qualitative research, you want to be as neutral as possible because you are interviewing both people who are pro and also against vaccine. So I'm just thinking, maybe is it better for you to not declare, but then tell them why you're not declaring so that, they feel comfortable discussing in a neutral situation?
Yes. Thank you for that question. So I knew that was probably more of a controversial point. And I think it's something that we're grappling with as a study team right now as we're thinking about the work that we're doing, just because for that specific study that I briefly introduced on healthcare workers in Ethiopia, it's a live topic. Things change every day. We're living through the COVID-19 pandemic still. And so, inevitably, we as researchers, it's not something of the past, it's something of the present. And so it's something we're really concerned about, that maybe we might have biases that we're not even aware of. Now, I'm not sure how this will play out in the field because we haven't begun our interviews, and perhaps we'll find that it's not necessary to disclose. But I think that, and I agree with you, that if possible, it'd be best sort of not to, just to lower all bias on the table. But if we find that, we might need to, and it's just a tool that we can use essentially. And so that's a tool that's on the table that maybe isn't the ideal, but it's certainly something to utilize if necessary. Yeah.
Right. Thank you.
Yeah.
Do you think we have time for just one more question?
Yeah, we have time for one or two more. Maybe we could take the one in the chat. I see there's one about someone who's working on a vaccine engagement project and is wondering about the factors to take into consideration when, obviously being labeled as vaccine hesitant has sort of a connotation. So what are the various factors that are important to investigate when considering someone's views on vaccination, and how does that relate to this idea of being vaccine hesitant?
Yeah, thank you. I think, so first and foremost, I think it's important to get to know the person personally as much as possible and as much as appropriate. So figure out who they are, what their occupation is, how they got there, perhaps ask them a little bit about where they're from, if they're willing to share, et cetera. What are factors that contribute to vaccine behavior? A lot of the time, specifically pre-COVID, it was their religious beliefs, it was their personal experiences, first and foremost. So what are their interactions with vaccination beyond their personal experience? Has their mother been vaccinated with the vaccine and had a negative experience or a positive experience? Do they vaccinate their children, et cetera? A lot of the times, you don't have to ask people specifically about what they do in order to understand their vaccine behaviors and beliefs and attitudes. You can ask them about vaccine behaviors of their loved ones, of people they are close with, for example. So that's one tool and one sort of set of questions that you can ask. For the sake of time, I won't elaborate, but happy to follow up with email as well.
Yeah, thanks.
Yeah.
I imagine even with COVID, we've learned some vaccine behaviors may be different with the COVID-19 vaccines than perhaps other conditions
Exactly.
of vaccines. So yeah.
Exactly. So true.
Great. So we just have a couple other questions. Maybe we'll just raise one, see how much time we have. So asking about the ethical acceptability of asking someone directly whether or not they're vaccinated, I imagine that might vary in different contexts, perhaps. So if you have any thoughts on that.
Yeah, absolutely. I think that's the answer, is that it just varies. I think a lot of the times we design the interview guide to sort of have that question outright and explicit, but like down later on in the interview, once there's rapport that's been established, because oftentimes you don't want to beat around the bush, because by beating around the bush, you can confuse people more, which is definitely not the goal either. I do think it is ethically acceptable to ask them, but just in the appropriate context. After all, they are signing up for a research study that's very clear that we're interested in learning about your vaccine-related behaviors and hesitancy. So it would almost be weird if you didn't ask them about that, because maybe for a lot of people that they're interested, they're fired up and ready to talk about it. You know, not everyone is very shy, by the way, in talking about this stuff. Some people are just looking for an opportunity to share all of their beliefs. And actually, on average, I think in my experience, I found that people really enjoyed being interviewed, at least the people who sign up to be interviewed, and they're more than willing to talk on average. Of course, you know, I conducted my research, my doctoral research in Israel, where people love to talk and like are disproportionately willing to share. Not true of every place, but on average, you know, people signed up for this study, and so it's okay to ask them in an appropriate way.
Yeah, I imagine it might also, as you said earlier, that people who ultimately do decide to get vaccinated can still be hesitant or may have been hesitant at one point in making their decision. So yeah, that's interesting to think about the relationship between vaccination status and hesitancy, for sure. Yeah, let me see if we have time just for one more question here. So there's a question, maybe we'll take the first part about maintaining anonymity. Yeah, I don't know if you have any thoughts. I'm looking at the chat here, the Q&A. There's a question about extent of maintaining anonymity, and then you know, questions about one's obligation to respond. I think the second question probably connects into your earlier point about the sort of duty or obligation to address misconceptions as well, but maybe this is a slightly different angle on that. But I don't know if you have thoughts on either of these.
Yeah, so I think that, you know, you can maintain the anonymity of your participants, you know, because generally these interviews are conducted only one-on-one. So generally there's not a huge study team who are knowing who you're talking to. So you have to make sure that the individual who is conducting the interview is really trustworthy and really keeps it a secret and is on board and is keeping the data anonymous, right? And therefore, you know, de-identifies the data when they save it. So when they're transcribing the interview from the recording, you don't want to write the person's name at the top of the interview. You want to assign them perhaps a participant number 1 or whatever, etc. To the second part of the question, what if we identified a crime during qualitative in-depth interview? Right. So I think that if this was identified, then I think that the interviewee should take it up with their principal investigator, so the PI, the lead of the study, and then hopefully they would be able to better assist them, because we don't want to ever make the interviewer feel uncomfortable as well. There's a lot of focus on making sure that the interviewee is comfortable, but because this can be such a stigmatized and testy topic, oftentimes we want to make sure that the person conducting the interview feels comfortable as well. And so if sensitive information arises, they should take it up with their boss. I do also want to highlight a point that you made, Joe, earlier, that vaccination behavior, so whether or not someone gets vaccinated, doesn't necessarily speak to their hesitancy. People can do an action such as getting vaccinated and still be very fearful or concerned about the vaccine. And that's why vaccination behavior cannot be translated into hesitancy or not. And that's a huge mistake. And I think that's also a huge mistake of how vaccine hesitancy is being communicated nowadays, that as long as you get the vaccine, so you're not hesitant. And I think that's super far from the truth. So just wanted to highlight that.
Great. Well, I think we're at the top of the hour, right, Julia? So perhaps bring it to a close here.
10 o'clock on the dot here, right?
Yeah. Well, Well, thank you again, Rachel, for joining us, and thanks to everyone for participating. As always, appreciate your attendance and discussion, and we're looking forward to continuing this work and hearing more about how it goes and how you've managed to thread this needle of doing some somewhat challenging research. So thanks very much.
Thank you so much.
Thank you, everyone.
Thank
See
you.
you
Have
all
a
again
good.
in the next session.
Thank you.